Xin chào tất cả các bạn. Hôm nay chúng ta sẽ được bác sĩ Esa Cohen đến từ Most Cancer Center tại UC San Diego Health trình bày về những dữ liệu cập nhật mới nhất tại hội nghị Esmo năm 2022 diễn ra tại Paris ở Pháp liên quan đến vấn đề điều trị tăng bổ trợ và giảm bậc điều trị trong bệnh lý ung thư khảo hào có HPV dương tính giai đoạn trung bình. Chúng ta cùng bắt đầu nhé.
Talk very loudly if you want me to, but it would be a lot easier if the microphone. Thank you. Okay, wonderful. So thank you, Sandra, for inviting me to, and the organizers for inviting me to talk about an induction and de-escalation approach for intermediate stage HPV. And what I'll do over the next 10 or 15 minutes is really set the stage with the data that we have in this disease entity. Here are my disclosures. So the first question I would ask, and maybe some of you in the audience are already asking this, is why revisit induction chemotherapy when about a decade ago we saw the conduction of 5 randomized clinical trials, phase 3 studies, to try and validate the use of induction chemotherapy in the setting of locally advanced head and neck cancer. And for the most part, those efforts were unsuccessful. And I know firsthand because we undertook the study at the bottom of this table, the so-called Decide trial. I see some investigators who participated in some of these other studies. But the hypothesis that induction chemotherapy followed by concurrent chemotherapy radiation improved survival was essentially not validated. 4 of these 5 studies were negative, with the Italian experience being the exception. The reason, though, to revisit induction chemotherapy in the setting of intermediate risk HPV is exactly what Sandra just told you, is that these patients do quite well. Here's the experience from the Cleveland Clinic recently published in Oral Oncology, where they specifically looked at intermediate stage HPV positive oropharynx cancer in the context of AJCC8. So this is the current and modern staging system. I show you the data for local regional control, and you can see for patients in the T1 to 3 with fewer than 19 PAC years, the survival is close to 100%. In fact, it's not that much worse in HPV positive patients who had more than 19 PAC years. So clearly, these are patients that have extremely high cure rates at 70 gray of radiation concurrent with cisplatin chemotherapy. And I think for most of us in the room that are treating these patients on a regular basis, we appreciate that concurrent chemotherapy radiation yields a high rate of not only acute, but more importantly, long-term toxicity. And we're beginning to see, as we see these patients now 4 or 5 years or more after the completion of radiation, that the toxicities do not abate. In fact, in some patients, they continue to worsen with worsening fibrosis. I hate to be trite, but some of us, not myself, but some of us have said radiation is the gift that continues giving in a sarcastic way. So the premise here is that we have a population that has an excellent prognosis, HPV positive intermediate stage. The expected overall survival is greater than 90%, and that we can use induction chemotherapy to reduce the radiation, either reduce the dose of radiation. I'll show you examples of clinical trials that have done that. The volume of radiation, I'll show you clinical trials that have done that, or perhaps even both the dose and the volume, dramatically reduce toxicity, especially long-term toxicity, and yet preserve survival. Because of course, the last thing we want to do in a patient population that is curable is sacrifice that cure rate. There are really two roles, or two potential roles, and one could probably think of more, but two primary roles for induction chemotherapy in this setting. One is to reduce disease burden, and the other is as a dynamic biomarker. So we know that HPV positive head and neck cancer responds at a very high rate to induction chemotherapy, including a high rate of complete responses. I'll show you the data to back that statement up in just a moment. And that distant relapse is actually a greater risk for HPV positive patients because we achieve such high rates of local regional control, as I showed you from the Cleveland Clinic experience, but I think it's across the board. But there's also another aspect of induction chemotherapy that we can take advantage of, and that is to use response to induction chemotherapy as a biomarker. Response to induction chemotherapy has been associated with a better prognosis, and that clinical response can actually be used to stratify patients for de-intensification, so-called adaptive designs, and I'll show you the examples of that. In fact, I'll show you the examples of that in just a moment. Here's a table of risk-adapted, and it's a little bit blurry, so I apologize, but hopefully you can see it. But here are some risk-adapted de-escalation designs that essentially employed the same principle. Take induction chemotherapy that we know to be effective, monitor the response of patients using different parameters, and I'll get into the details in just a second. And for those patients who had a good response, and that was defined differently in the different studies, give those patients less radiation. And that can be achieved by eliminating the systemic portion of concurrent chemotherapy radiation, eliminating the chemotherapy, in other words, by reducing the volume of irradiated tissue, or by reducing the dose. The study at the top did the latter. The ECOG 1308 took patients using a relatively newer or somewhat unique induction regimen of platinum, taxane, and cetuximab, looked at patients who had a complete response at the primary site, and gave those patients a dramatically reduced dose of radiation to 54 gray. And what they found was actually that those patients that were good responders did very well in the long term. Patients with very advanced T-stage or end-stage were the ones that unfortunately didn't do well. But that's not the patients that we're talking about in this session. We're talking about intermediate stage. So in terms of that, ECOG 1308 was somewhat successful. I'll draw your attention to the second study in this table, and this was one that we conducted when I was at the University of Chicago. And we took somewhat similar approach, except we took both HPV positive and HPV negative. What we did was use induction chemotherapy, again, platinum, taxane, and in this case, an mTOR inhibitor called everolimus. We defined good response as a 50% reduction by RECIST, and that was somewhat arbitrary, but we thought that 50% was good enough. But what we did was that we didn't change the dose of radiation, we changed the volume of radiation. Patients who achieved that 50% reduction or more only received radiation to gross tumor volume. So PTV1 and PTV2 were spared. What we saw was no local regional failures in PTV1 and PTV2. So in other words, eliminating those radiation fields in patients who were good responders did not sacrifice survival, did not sacrifice local regional control. What it did was it dramatically reduced the rate of G-tube installation and long-term toxicity. Optim, the next study in this table, did something very similar, but using a slightly different induction chemotherapy regimen, but the principle was the same and the results were the same. I'll actually show you Optim in just a second. Optim 2, again conducted by the University of Chicago, is interesting because now this incorporates immunotherapy, an anti-PD-1 antibody called nivolumab. Here is the Optima study, so it's a phase 2 dose and volume de-escalation trial, and I think it's very interesting because this was a specific study for HPV positive oropharynx cancer, and this was recently published in Annals of Oncology. And here you see the survival data. It's pretty remarkable. This was, in my interpretation, at least from a phase 2 perspective, a very successful approach. Patients who were at intermediate risk, HPV positive oropharynx cancer, who were responsive to induction chemotherapy, essentially had 100% survival at 2 years. Here's an opportunity to use induction chemotherapy in an adaptive manner to reduce radiation, but not sacrifice survival. But of course, we're in the era of immunotherapy, and as you might guess, or as many of you already know, now we're integrating immunotherapy into either by itself as induction or with chemotherapy. And here's an example of the multiple clinical trials, and this is actually just a short list because there's more, but some of the clinical trials that have incorporated this approach, either as anti-PD-1 antibody alone, and you can see examples of nivolumab and pembrolizumab, or with nivolumab and ipilimumab, or at the bottom, durvalumab and tremelimumab. So either anti-PD-1 or anti-PD-1, PD-L1, and anti-CTLA-4. And what we've seen fairly consistently is that there is a response to checkpoint inhibitors in locally advanced disease, and that there's a pathologic major response that we see in some patients. However, the pathologic complete response rate is still relatively low. And so my interpretation is that immunotherapy alone, at least when we're talking about anti-PD-1 for a limited number of cycles, is probably not enough to get us to where we want to be. I think we need pathologic complete response rates that are much higher than we're seeing with anti-PD-1. And so with that in mind, let me introduce a concept that we're now undertaking in collaboration with our colleagues in Providence and in Portland and at OHSU. And this derived from the experience by Providence investigators using both immunotherapy and stereotactic body radiotherapy as a neoadjuvant approach. And I cheated a little bit in that all these patients did actually receive TORs. So now this is a combination of all three modalities. But allow me to focus on the neoadjuvant portion of this clinical trial. As you can see, they enrolled patients on the left-hand side with HPV positive disease into 3 cohorts, and those cohorts just changed the SBRT. The critical factor here is that not only was an anti-PD-1 antibody used, the antibody nivolumab, but SBRT was delivered only to gross tumor volume in a hypofractionated, limited radiation manner, with the idea that if one could achieve a high rate of pathologic complete response, and of course that would be recognized with TORs at the back end, you would be able to preserve survival and improve long-term toxicity. And that's exactly what the investigators saw. In fact, if I draw your attention to the bottom panel of this graph, you can see that in the HPV positive cohorts, almost every patient achieved a pathologic complete response. So the combination of immunotherapy with limited radiation that is relatively less toxic than the 70 gray given over 7 weeks may be a way to achieve exactly what we want to do in intermediate stage HPV positive cancers. And so we've taken this forward, again with our partners, and have now incorporated an anti-CD47 antibody that showed some very interesting, promising data in recurrent metastatic disease called evorpacept, in combination with an anti-PD-1 antibody pembrolizumab and the same SBRT regimen as cohort 3 in the Providence experience, that is 8 gray times 3. That's done as a neoadjuvant approach prior to TORS resection, and then stratified adjuvant therapy depending on the pathologic response. But we actually expect that the majority of patients on this study will have a pathologic complete response and be observed after resection. Here's the schema that you see over time. The anti-CD47 and pembrolizumab is given in 2 cycles prior to surgery. So I'll leave you with a few thoughts on intermediate stage HPV and this approach of induction followed by radiation. That induction chemotherapy prior to lowered intensity radiation or chemotherapy radiation has been successful, at least in phase 2 trials, if we define success by long-term survival and long-term toxicity. We've seen improved short and long-term toxicity, and I think if we look at the data, volume reduction, so that is eliminating PTV1 and PTV2, may be the better way, and this is a bit of editorializing, the better way to lower long-term toxicity. We, of course, have to see that play out. We've seen survival preservation. Again, these are all phase 2 studies, but what we haven't seen is really testing this concept in a phase 3 trial, at least not yet, but those are planned and actually now ongoing. The future directions really include further integration of IO agents, doublets, and perhaps even triplets, because I think what we really need is pathologic complete responses. Of course, if we're eliminating surgery, we won't know that for sure, but at least complete responses clinically. Because those are the patients that appear to have the extremely good prognosis. And then, of course, we all, I think, are looking for integrating biomarker-based stratification, and circulating tumor DNA appears to be a readily available way to do that in the near term. And of course, there are studies underway doing that. So again, I'll thank you for your attention. Thank you for the invitation. And am I introducing the next speaker, Sandra, or are you? Okay, so I'll do it. Dr. Simon, I'll introduce you as talking about TORS in the application for HPV positive intermediate stage.